got a superficial perivascular dermatitis. That's also interface change. Interface. Okay. You got a few scattered disc keratotic keratinocytes. You've got some melanophages here. You got a perivascular lymphocytic infiltrate. And you've also got some mucin in the dermis here. Not all of this is ciliary elastosis. Some of it is also mucin as well down in this area. So your choices here of these, the only one that might confuse you might be erythema multiforme, but it really didn't have it's got effacement of the epidermal rete. It's got a few disc keratotic keratinocytes, not the same degree that we saw the EM. This is a more chronic process. So the best answer here is a late stage variant of subacute lupus erythematosus, which is the choice here. Subacute LE. So choosing this in EM, a little bit more challenging here, but they probably wouldn't put that on there. But this is a good example of a more long-standing lesion of somebody that had known subacute cutaneous lupus erythematosus. They might even show you some that's got some more vascularly cornified. Might even show you some parakeratosis if one was they're going to show you a classic example of this. So an example of subacute LE, a little bit different than the case of erythema multiforme that we saw before. Excisional or maybe a deep punch biopsy. Epidermal hyperplasia with pseudocarcinomatous hyperplasia, some cells down here that look like they're kind of pale. We start looking at it at higher magnification, and they've got this characteristic granular cytoplasm to them. Bubblegum kind of color plus granules. With the overlying pseudocarcinomatous hyperplasia, this is yet another one of these cases where you want to be able to recognize these cells. This is a granular cell tumor. These cells are in the family of neural differentiation. These cells are trying to make myelin. They fail, and they form lysosomes of Schwann breakdown product, myelin breakdown products, positive with S100 protein and PAS. So your choices here, it's certainly not xanthoma. Now you might say, Malakoplakia, what does that look like? You know, when we see that. We get these Michaelis-Gutmann bodies, these very eosinophilic pink structures associated with a lot of inflammation, granulomous inflammation. Doesn't look anything like this. If they put something on there that you haven't seen, and there is something that you have seen, don't get thrown for, a loop on that. Say, well, they're probably just throwing in something from outer space to try to confuse me. And I know this is a granular cell tumor. So don't choose something funny that doesn't make any sense. Stick with something that you've learned and that you know. That's diffuse inflammatory infiltrate here. All right. So very, very diffuse infiltrate here. Something's going on here that's very, very diffuse. And is it inflammatory or neoplastic? We're not really sure initially. We start looking at higher magnification, and no, it's not inflammatory. It's got all of these spaces here. And these are neoplastic cells at low magnification. Maybe they could be histiocytes, but with the higher magnification, these are neoplastic cells. And these cells are very atypical. They vary markedly in size and shape. There are a lot of cells that are necrotic. There are cells that are in mitosis in here. And this up here demonstrates these blood vessel changes with these staghorn morphology and these atypical endothelial cells that are floating freely in the lumen of these atypical neoplastic blood vessels. This is a classic angiosarcoma. It's almost got an epithelioid morphology down in this area. Sometimes these get so cellular that they can simulate a squamous cell. And there are actually variants called epithelioid angiosarcoma. So this is angiosarcoma. It's certainly not a hemangioma. It's not capsular sarcoma. That doesn't give you these large atypical cells, these epithelioid cells. It's more of a spindle cell morphology. It's not any of the other conditions that we've talked about, not an acantholytic squamous cell. These are actually neoplastic blood vessels here. So hopefully you guys recognize that. They might show you an example of one of those on the board examination also, because they're so important to recognize. Okay, we've got a excisional biopsy of a neoplasm with these kind of irregular cells here and cords and strands with this thick stroma. You got some dystrophic calcification. And this is an example of a morpheaform basal cell carcinoma. Now, the differential diagnosis of this includes microcystic adnexocarcinoma and desmoplastic tricho. They're probably not going to show you those three without some other kind of things, because can I say with absolute certainty there's no chance this could be a morphiiform basal cell carcinoma or a microcystic adnexocarcinoma? Probably not. We chose an example to show you the fact that these all look kind of different. They list microcystic adnexocarcinoma here as a choice, and I'm not sure that would be fair for this. So basically recognize this is a sclerosing epithelial neoplasm. Usually if it's a basal cell, they're going to see a focus of obvious basal cell in one area or another. So here, this is thought to be morphiiform basal cell, but this could look very much like a microcystic adnexocarcinoma. So they're not going to do what we did to you on this question here. They're not going to ask you to distinguish between those two, because this really could be that. Those usually involve nerves. So if you see neurotropism, it's more likely to be more a MAC than a morphiiform basal cell carcinoma. So just recognize this is one of the examples of these sclerosing epithelial neoplasms, less likely to be desmoplastic tricho and more likely to be either morphiiform basal or a MAC. Okay, here we've got a biopsy taken from acral skin. It's pale at low magnification, but you can see as we get to higher magnification, it's got these fascicles of cells. It looks almost like muscle a little bit here. But if you look carefully, it's got these periapical red dots surrounding them. This is a subtle finding, but it's present. Here's another one. And they probably wouldn't show you this without giving you a clinical photo, but this is an example of a infantile digital fibroma. This is what these lesions look like. These are thought to be fibrohistiocytic, or maybe they're even related to smooth muscle lesions, but they characteristically give you this this very apical pink dot, like you see right there. And they'll show you a picture of this. It's a dome-shaped lesion on the digit of a child, and then they'll show you that, and they'll show you this pathology. This is what it's supposed to look like. So make sure you can recognize those little periapical pink dots at the tip of these things. That's very classic for this lesion. Okay, 56. Here we've got a deep incisional biopsy. And notice that there's all this calcification of the subcutaneous fat here with all this inflammation surrounding it. This is small, fine, stippled calcification of the fat, stippling with this inflammation. And maybe if we look carefully above here, we might even see some thrombosed blood vessels here. And if they're going to show you this on the board, they're probably going to show you some epidermis with necrosis. And here we do probably have some thrombosed blood vessels up in this area. This is calciphylaxis. Calciphylaxis, not just dystrophic calcification. That usually gives you large aggregations of calcium. But when you start getting these small stippled areas of calcium in the fat, like you see here, it's virtually pathognomonic for calciphylaxis. If you get secondary calcification of blood vessels with overlying thrombosis and destruction and necrosis of the overlying epidermis, degeneration of collagen, it's basically nothing else will do that. So calciphylaxis, remember this, it's not just coincidental incidental calcification. This one we put on here, they had this on my boards many years ago. It's a benign neoplasm of fat, but notice it's got these cells that have these very characteristic structures to them. It looks almost a little bit like the granular cell tumor, but these look different. These are not little granules. These are small little foci of mitochondria within the fat cell. So remember this. This is another one of these. You have to memorize kind of what it looks like and be able to recognize this. This is brown fat. And this is an example of a hibernoma. Hibernoma. They had this on my board examination. I'll never forget it. 50 some odd almost years later, not quite that long, but I remember they had this. And then the next slide was molluscum. And I thought, well, why are you, basically you're insulting my intelligence by putting molluscum on it. So, well, this is a good slide here because you have to know what brown fat looks like. But then they put molluscum, then anybody can get it. High school student can get that. So make sure you know what brown fat looks like. And this is a beautiful example of a hybridoma. So they've had it on the test before. They can have it again. Okay, next, excisional biopsy. We've got this lesion down here in the dermis. And notice it's got these whorls of spindle cells associated with this scar-like structure. And if you look carefully, these are little small axons of a nerve. So what happened here? This person got an injury and developed this traumatic neuroma. And it was probably painful because we know neuroma is one of the painful tumors. They probably said, this is hurting me when I rub the area or walk or whatever. I want to remove it. So this is a traumatic neuroma. These are little nerve twigs here. There's the nerve. And these are little axons. And they're basically, it's undergoing Wallerian degeneration. Scar, plus these irregular fascicles of nerves that are embedded in this scar tissue. Traumatic neuroma. The most common place we see this is in an amputated accessory digit. That's where we classically see traumatic neuromas. Not any of these other entities. It's not a neurofibroma, not a schwannoma. These are nerves. It's not schwannium, and it's not a perineurioma where you have a nerve surrounding these whorls of these spindle-shaped cells here. These are irregular nerve twigs that are formed by their undergoing this degeneration, Wallerian degeneration. Okay, punch biopsy. Hopefully you recognize there's some inflammation going up here in the epidermis here. And you can see that these are not all lymphocytes, and these blood vessels are involved here. If you go to higher magnification, this has got classic example of leukocytoclastic vasculitis. Neutrophils, leukocytoclasia, extravasated erythrocytes, often some eosinophils here, fibrin in the wall of the blood vessel here, and maybe even thrombosis of the lumen of this blood vessel over here. So this is beautiful, classic example of leukocytoclastic vasculitis. This could be IgA-mediated vasculitis, could be vasculitis-related to lupus or connective tissue disease. We don't know the cause of it. If we did immunofluorescence and saw IgA, well, then we favor HSP. But this is, you have to know what this looks like. You will get a question on this on the board examination. It's pretty classic. Nothing else down there looks like that. It's not Sweets, not Schamberg's, none of the other examples of that. This one, punch biopsy of a diffuse dermatitis, diffuse in the upper part of the dermis, and it's got this dense infiltrate superficially with this massive papillodermal edema. And hopefully you can appreciate even at this power that these are not lymphocytes once again. So as we go to higher magnification, they're all neutrophils. Tons of polys with papillodermal edema. That diagnosis is Sweets disease. Classic Sweets. Not vasculitis, not leukemia cutis like we saw before, not an abscess. Basically, you see this, it's diagnostic of Sweets or bullous dermatosis of the hands, which is basically a type of Sweets. Not as good for pyoderma gangrenosum. That's an ulceration. It also can have a lot of neutrophils in the infiltrate. Does have neutrophils, but does not give you the papillodermal edema. So if you saw this, even if PG's in the differential, you wouldn't choose it. You'd choose Sweets. Beautiful case of that. Okay, we've got here a superficial perivascular dermatitis with somewhat of a band-like infiltrative cells up here. Go to higher magnification. There's prominent epidermotropism. And then we start looking to see what kind of cells they are. And notice that they've got these nice reniform nuclei. Reniform nuclei. They're not histiocytes. Nuclei that look like kidney beans, and they're in the epidermis, and there's infiltrative lymphocytes and eosinophils in the dermis. This is a beautiful example of Langerhans cell histiocytosis. You get several other choices here. You might say, well, gosh, could this be HTLV1 lymphoma, leukemia? that doesn't give you the reniform nuclei like you see here. This obviously also is not a good example of mycosis fungoides. They might show you something like this with a CD1A stain, and then maybe ask you some of those things in the differential diagnosis. But this is a nice example of Langerhans cell histiocytosis. There's no band-like infiltrate. There's no thick collagen bundles like we would see in MF. No classic histologic, cytologic features of the cells of mycosis fungoides. These have abundant cytoplasm, so they're more likely Langerhans cells. So that would favor the diagnosis of Langerhans cell histiocytosis, given that you have these as choices. All right, number 62, an incisional biopsy. We've got all these large cyst-like structures with this dense diffuse infiltrate involving the subcutaneous fat, the dermis. We've got granulomatous inflammation. We've got these large irregular cysts. We've got diffuse inflammation. We've got scar tissue. So what's going on here? It doesn't look like any of the classic inflammatory skin disease that we look about when we look in the textbook. And so we start looking and say, well, look at these choices. Suture granuloma? No way. This is way too dense. It's got the scar tissue. It's got all these granulomatous areas with foamy cytoplasm. It's got these large fat microcysts. This is an example of a paraphenoma, something that was injected by someone. So this is a factitial disease. Doesn't look like a classic inflammatory process. So when you see something like that, you should think about factitial. And these people inject all sorts of things in their skin. They can inject oils, they can inject silicone, they can inject real paraffin. If you polarize this, you might see polarized before material. So this is an example of a paraphenoma. Paraphenoma. Another example of a punch biopsy, very dense, very diffuse process involving the subcutaneous fat. And it's almost got kind of a diffuse honeycomb-like pattern, but it's not the DFSP. And then it's mostly a lobular paniculitis. So once again, lobular mostly, maybe septa involved here too, but this is 90% lobules, 10% septa. There might even be some involvement in the upper dermis up here too, okay? And let's take a look and see what kind of cells these are. So we look at once we decide it's lobular versus septal, what kind of cells are in infiltrate. And here we've got almost totally lymphocytes, and some of them are a little bit atypical here, and they seem to be homing, almost like they've got an address here. They're zooming into that address around these lipocytes and these fat microcysts here. So this is a beautiful example of a subcutaneous paniculitis-like T-cell lymphoma. There's the alpha beta subtype, which is now thought to be a subcutaneous, lymphoproliferative disorder. And there's the gamma delta subtype, which is a more aggressive form of this condition. So when you see this pattern, looks like a lobular paniculitis, and it's consisting almost wholly of lymphocytes, no granulomatous inflammation, nothing else. And they're just kind of zooming in, homing into the lipocytes. I want you to think about the subcutaneous paniculitis-like T-cell lymphomatous process. Good example of that too. All right, we've got another punch biopsy here. And we've got a superficial and deep infiltrate that's fairly diffuse. It's got some superficial involved in the epidermis here. We start looking at higher magnification. These cells are very, very atypical. So we say, gosh, maybe this is some kind of a lymphoma. And it does have this area where it looks like there was some epidermal involvement. Maybe there's some crusting. And here's one that would probably give you a CD30 positive stain with this. This is an example of lymphomatoid papulosis, or one of the CD30 positive lymphoproliferative disorders. And the key to that is these very large atypical cells here with a lot of eosinophils. So looking at your choices, you had secondary syphilis, don't look anything like that. It certainly doesn't look like Pernio or EAC or LE. So of the choices, even though they didn't give you a CD30 stain, this is the only one that makes any sense. So sometimes they give you an answer that you can figure out just by process of elimination. They're saying, well, okay, so we're not going to give them the definitive stain that would make the diagnosis so that anybody could get it. We're going to make them work through the answers and figure it out. And so when you look at these other answers, none of those work. So it has to be lymphoma papulosa, even without the CD30 stain. And it does show the features, the nodular infiltrate, dense diffuse infiltrate, sometimes wedge-shaped, the EOs, sometimes involves the epidermis and gives an epidermal necrosis with an eschar at the top. So you'll see that on occasion, but at least here, it's a nice example where the choice is allowed you to make the diagnosis. All right, here we've got a very dense infiltrate of cells here, probably inflammatory. We start looking at higher magnification, some lymphocytes here, but also these cells that are relatively darkly stained. And we've also got these cells that have got the foamy cytoplasm at the central nucleus. We've got a lot of eosinophils here also. We've got a fair number of those cells. And here's another one. These are Teuton giant cells. This is an example of a juvenile xanthogranuloma in a relatively early inflammatory stage before you get a ton of Teuton giant cells. And if you get these lesions early, they can look like this. There are Teuton giant cells in here, and you have to recognize them, but just also recognize that if you get an early inflammatory stage of XG, you may get a lot of eosinophils in that and lesser numbers of Teuton giant cells. Okay, so if this is a juvenile xanthogranuloma, they might ask a second-order question about XG, associations with juvenile myeloid leukemia. You can get multiple widespread lesions that can involve the eye and internal parts of the body, such as the adrenal gland sometimes. So just recognize it's not always a cutaneous limited disease. Okay. Another example of a fairly classic entity here. We've got a superficial and deep infiltrate, mostly lymphocytes, but also interface change here. And notice that there's something going on in these hair follicles. Lymphocytic infiltrate, interface dermatitis, thickening of the basement membrane zone, follicular plugging. This is discoid lupus erythematosus. DLE. Maybe some mucin in here, but you don't need mucin. It's not a criterion for diagnosis. Sometimes you get mucin and sometimes in lupus, and sometimes you don't. So don't use it as criterion, use everything else. Beautiful example of lupus here. Marked thickening of the basement membrane zone over here. Hope you're able to get this one right. Pretty classic. Nothing else really in the list should have caused any concern there. Okay, here we've got a punch biopsy, and we've got a dense collection of this bluish material in here. Notice this time, it's forming a lake of this material. This is calcinosis cutis. This is classically what you see when you see it in the scrotal area. But notice the difference between this and the calciphylaxis case we had a minute ago. No inflammation here, just a big lake of calcium deposits. So we know what caused this. You know, it's certainly not colloid milium. It's not any of the other materials that are listed in here. This is testing your ability to recognize this as calcium. So this basophilic calcified material that you see here, this is classic for calcinosis cutis. All right, moving on to the next one. A shave biopsy here. At low magnification, hopefully you can appreciate the papillodermal edema. This is sclerosis of the papillary dermis. This is classic for lichen sclerosus erythrophagus. Classic for it. So they're probably going to show you something like this that'll be pretty classic on the exam. Notice the thick cornified layer. This is itchy. It's rubbed. Occasionally you can bullous LSNA. The epidermis shears away from the sclerotic collagen, or there's edema of that papillary dermis. So again, this is a beautiful example of that. Plasma cells in the infiltrate. If they put syphilis as a choice, please don't choose it. This is not chronic graft versus host disease. There's no sclerotic irregular collagen with the irregular bizarre fibroblast here. This has got edema, which you usually don't see in chronic radiation dermatitis. I'm probably not going to show you that to distinguish among those two, but nevertheless, this is a good example of lichen sclerosis that hopefully you all were able to pick up pretty easily. Okay, 69 here. We have this in here to compare with the xanthelasma. This is an example of eruptive xanthoma. Notice that these cells almost look a little like GA. These cells have flown into the dermis quickly. They also can fly out of the dermis quickly. If you take these people's lipid levels and reduce them to normal, believe it or not, these lesions can almost vanish before your eyes. They can disappear very quickly. Notice the extracellular lipid here. It almost looks like mucin. It's bluish gray. So you get the lipidized histiocytes here, like in eruptive and other kinds of xanthomas, but you don't get the extracellular triglyceride in those conditions. And here's some little triglyceride crystals here, most likely. Beautiful example of an eruptive xanthoma. It actually looks more like GA than it does like other kinds of xanthomas. And you have to recognize the extracellular lipid to be able to distinguish it from GA a lot of times. Okay, this looks different because it's cut funny, but the clue to this diagnosis is recognizing the changes in the fat. These are granulomatous areas here with crystals in the fat and in the histiocytes. And sometimes they'll show you kind of a weird lesion. I remember they showed us on our board example a really bizarre high-power view of KS clinically that looked really weird. It almost looked like just a sea of purple. It didn't really look like a tumor. So sometimes they'll do that. So this is basically just an incisional biopsy of the fat here. And they've got all this inflammation with these granulomatous, this is granulomatous inflammation with these crystals. This is subcutaneous fat necrosis of the newborn. You've got to recognize these are crystals in the fat. They have higher levels of palmitic acid in their fat when they have this abnormality than other children do. And they just kind of precipitates out and they get this granulomatous inflammation with crystals. So this is one of the crystalline paniculitides. Classic example of that. Another paniculitis, lobular paniculitis with fat sclerosis and hyaline degeneration of the fat with these aggregates of lymphocytes and plasma cells at the periphery. Classic example of lupus erythematosus profundus. Lupus profundus, hyaline fat degeneration. And I don't think this usually has too much difficulty in distinguishing this from the subcutaneous paniculitis like T-cell lymphoma. You got a little bit of lymphocytic infiltrate left up in the dermis. Sometimes you get a little bit of DLE up at the top. We don't see that here. This is a beautiful example of lupus paniculitis. None of the other diagnoses should have caused confusion. So we're going to pick up this hyaline fat necrosis, very, very characteristic. All right, here we've got another deposit, pathognomonic deposit, feathery, grayish ghosts, crystals of gout, gouty tophus. And this one's got a little bit of granulomatous inflammation in the periphery and sometimes simulated palisated granuloma. But this is yet another one where you need to recognize this feathery, grayish light. It looks almost like a cloud, feathery cloud, gray cloud with granulomatous inflammation. This is a gouty tophus. Nothing else looks like that. Pseudogout, calcium oxalate, that never occurs in the skin, basically. They're not going to ask you that. Certainly none of the other deposits that are listed on that list. Okay. This one's pretty much pathognomonic also. Got an excisional biopsy here of a lesion with the calcification giving the classic ghost-like cells. Calcification over here, and then the residual cells of the inferior portion of the follicle over here, the matrical cells, is polymatricoma. They would probably expect you to get this right away. And they might say, which diseases have been associated with this? And there's about 3 or 4. Friedreich's ataxia, glioblastoma multiforme that was described by a dermatologist a few years ago. So once again, they might ask you about that. So make sure you know some of the other disorders that can be associated with polymatricoma. Beautiful, classic example, no problem with diagnosis in this case. Number 74, neoplasm, comprised of these small spindle-shaped cells with this fine fibromucinous stroma. They're just kind of swimming lazily within this. This is a beautiful example of a neurofibroma. Beautiful neurofibroma. No question with this. Hopefully this will be an easy one for you to distinguish. And they don't look like any of the other choices. Another example, a pathognomonic, classic central cyst, radiating miniature baby little hair follicles coming off that mother cyst with the white tuft of wool coming out of the center of it. Beautiful example of trichofolliculoma. Trichofolliculoma. Nothing else looks like that. Classic. Hopefully you didn't have any trouble with this one either. Okay. Excisional biopsy. What, it's got this papillomatous appearance to it. Lots of sebaceous lobules. Many of them are not associated with follicles. Some of them are dumping directly into the epidermis. We don't see any other adnexal tumor associated with this one, although we would often see a syringocystadenoma papilliferum with this. This is a beautiful example of a nevus sebaceous. Hopefully you guys all got this without any trouble. So again, nevus sebaceous of Yadison. Number 78, small papule this time. Sebaceous cells kind of forming a crateriform papule, dumping into the epidermis with a greater than 50% mature sebaceous elements versus immature sebaceous elements. Good example of a sebaceous adenoma, often associated with the Muratori syndrome. Might be loss of MLH1, PMS1, 2, MLH2, MLH6, so you get loss of that, microsatellite instability. Make sure you know everything there is to know about the Muratori syndrome. Epithelial neoplasm emanating from the epidermis with these sheets of these round clonal poroid cells. Beautiful example of an ecrine poroma. Ductal differentiation. Notice that it's contiguous to the epidermis. So a poroid hydradenoma is a similar appearing cells in the dermis, with that cutting to the epidermis. Hydroacanthoma simplex is kind of like a poroma in situ, and then tumor of the other forms of poromatous lesions that you can see. Tumor of the name escapes me. It's listed as a choice there. Anyway, that's another one that you see: poroid hydradenoma, hydroacanthoma simplex, poroma, and the other one that you can see that I'm not remembering right now. So anyway, those are the poroid lesions that you need to know. Number 80, a lesion with basaloid differentiation. Nice example of the little cylinders of cells with the pink hyaline rims surrounding them. Beautiful example of a cylindroma. Okay, now sometimes you'll see a cylindroma plus a spiroadenoma together. That's more commonly seen in Brooks-Spiegler syndrome. Spiegler. Again, the nice example of the rims of the pink material surrounding all these. Turban tumor, cylindroma. Number 81, blue balls in the dermis. Here, comprised of these cells with little pink hyaline droplets within them. Again, this is a spiroadenoma. And here, you got a couple areas that look a little bit like a cylindroma. So there's a little bit of an overlap between those two occasionally. but better for spiroadenoma, one of the painful tumors. Okay. Or 82. Another adnexal neoplasm. So these are all relatively simple. These are ones you just kind of have to know. You've got a dermal-based neoplasm with apocrine differentiation. Notice that it's not contiguous to the epidermis, and you'll often get little aggregates of plasma cells in the center of these. Okay, this example of the hidradenoma papilliferum. Hidradenoma papilliferum. Okay. Hidradenoma papilliferum. Come on, load up for us here. Tumor with a lot of mucin and cartilaginous differentiation coupled with areas of ecrine differentiation. Chondroid syringoma. This is what's called the syringomatous component. Here you see chondroid. Here you see some osteoid that's formed in here. So this is cartilaginous metaplasia, chondroid syringoma. Another pretty straightforward one. Here we've got the same type of lesion that's contiguous with the epidermis that we saw, the hidradenoma papilliferum. This is syringocystadenoma papilliferum. Syringocystadenoma papilliferum. These are often associated with nevus sebaceous. They don't have to be. The other poroid lesion, by the way, is dermal duct tumor. I failed to mention before. So we've got this syringocystadenoma papilliferum. Okay. Now we've got a, let's see, number 85. Is it? Something's wrong here. 85. Here we go. Here we go. Neoplasm of fat. Shelled out. Benign, right? Fat cells plus these little glomeruloid vessels equals angiolipoma. Angiolipoma, one of our painful tumors of the skin. So there's about 4 or 5 different fat tumors you need to know. Make sure you know fibrolipoma, make sure you know myxoid lipoma, make sure you know spindle cell lipoma, make sure you know this variant of lipoma. Angiolipoma. All right. We're switching back to an inflammatory process here. Nodular dermatitis diffuse, pale cells, histiocytes predominate, few lymphocytes, pattern of granulomatosis inflammation, sarcoidal, classic example of sarcoidosis. Sarcoidosis. Beautiful. Beautiful example. They have lepromatous leprosy in there. That gives you a diffuse granulomatous pattern, not a sarcoidal pattern. The tuberculoid form of leprosy gives you a sarcoidal granulomatous dermatitis, and it's elongated granulomas around neurovascular bundles. So don't confuse that. And it doesn't look like anything else that we got there. Well, let's look at this one. We've got a diffuse dermatitis here with pale cells, granulomatous once again. We've got a high magnification. I hope you're able to realize and appreciate that these were foamy appearing cells and diffuse pattern, a Gren zone here. Look at these cells here. They've got little tiny structures inside them that are known as globi. This is lepromatous leprosy, not tuberculoid leprosy, lepromatous leprosy. If we did a fight stain, all of these would light up like a Christmas tree. Very strongly positive, multibacillary disease, lepromatous leprosy. Okay, number 88. Okay, so these last few cases, suppurative granulomatous dermatitis with epidermal hyperplasia, you need to immediately be thinking about an infectious disease. When you see that, you want to go on a bug hunt. You go looking for organisms. Where do you look? You look in the areas of suppuration, and there's lots and lots of organisms here, lots of them, with the broad-based buds here. Broad-based buds. Broad-based buds equal blasto. So look there, look up here. A lot of times you get transepidermally eliminated, like here. And then look inside the histiocytes. Sometimes you look in the multinucleated histiocytes, and the histiocyte is kind of forming a background cell where there's, the cytoplasm. There's some inside this histiocyte. So that's where you look. This guy's got so many of them, you look everywhere. So he might have been an immunocompromised patient. So that's blastomycosis there. Okay, 89. We've got a biopsy that shows a round nodule sitting here in the dermis. It's got pale cells with lots and lots of blood vessels here. Pale plus blood vessels doesn't look like any typical adnexal tumor. Certainly doesn't look like a typical hydradenoma. There's no ductal differentiation. There's actually the formation of these little nephrons here. Nephrons. This is metastatic renal cell carcinoma. Metastatic renal cell cancer. Scalp is a common site of involvement. Looks like the biopsy was taken from the scalp. So you need to be able to recognize this lesion also. It's not a pyogenic granuloma. It's not mostly vessels. It's vascular. It's not mostly vessels. We mentioned why it's not adrenoma a minute ago. Okay. Shave biopsy again. Dense diffuse inflammatory process. Pale up at the top. Lymphocytes, probably some plasma cells down here, maybe. We'll see in a minute. Pale at the top. That's a clue. Pale at the top. Pale, we go to our identification, and guess what? We've got all these cells that have these marquee signs in them. These are histiocytes. Pale equals histiocyte, filled with organisms. Leishmania. This pattern, if you see the low magnification, pale plus dark beneath, think leishmania. Pale, dark, leishmania. Leishmania like to live where it's cooler. They live at the top of the skin, more likely at the top of the dermis and in the epidermis. And the inflammation is at present beneath it. Leishmaniasis, beautiful example. Not leishmaniasis. You guys remember Archibald MacLeish, the poet? He was a Scotsman. So you don't say leishmaniasis like a German EI, it's Leishman. Leishmaniasis. 91. Once again, a lot of pseudocarcinomatous hyperplasia, suppurative granulomatous dermatitis, neutrophils. We're going to look for organisms again, right? Bugs, pseudocarcinomatous hyperplasia. Where are we going to look? We look in the neutrophilic areas, like right here. Any bugs in there? Not so sure. Let's look down here. Ah, now we have some inside a histiocyte. Brown. Here's another area. Copper pennies. Copper pennies. Medlar bodies. Diagnosis is chromoblastomycosis. Chromoblasto. Here we got another one. Lots of them here. And that's when they show you on the board. They're going to show you enough that you're going to be able to find it. They're not going to make you spend an hour looking. You have 2 minutes a slide, so they're going to give you some time to find. Chromoblasto. Make sure you know a few of the organisms that cause it. They might ask a couple of organisms to see what caused it there. Okay, we're not going to stay. We're going to make you flip around a little bit and not just go from one bug hunt to another. So here's a neoplasm, shave biopsy, small, symmetrical, well circumscribed. What kind of differentiation? Nested, maybe melanocytic. kind of a type of epithelium. Higher magnification, epithelial and epithelioid and spindle-shaped cells and nests, camino bodies, dull pink bodies, epidermal hyperplasia, Spitz's nevus. Spitz's nevus, not malignant melanoma. They have Spitz's nevus, Spitzer melanomas of choice, but it's small, symmetrical, well circumscribed, benign. We're not going to get worried about it just because it's got a couple of atypical cells, maybe. Don't go down the pitfall. Benign here. Obvious Spitz's nevus. Okay, 93. We've got a shave biopsy. Spongiotic inflammation here. Spongiosis maybe, some inflammation, but something's going on in the epidermis. Acanthotic. We start looking and, whoa, this doesn't look very good at all. There are these multiple cells, all levels of the epidermis, including the granular cornified layer. There are cells at the basal cell layer even. Atypical. Clusters of cells. Mucin in the cytoplasm. Pagetoid pattern. So you instantly go to your pagetoid differential diagnosis pattern. Melanoma, Merkel's cell, Langerhans cell histiocytosis, Patch's disease, extramammary Patch's disease, mycosis fungoides. Which of those fits here? Which of those fits in this situation? Well, we have a number of them there, but we think it's probably going to be Paget's itself. Large cells, clusters of cells, mucin. They might show you a type 7 keratin 7 stain here, CK7. They might show you a mucicarmine stain or CEA stain. So this is Paget's. It doesn't really look like sebaceous carcinoma at all. It doesn't look like Langerhans cell histiocytosis. There's nothing in the dermis. It's confined to the epidermis. It's not melanoma. Okay, good. Next one. Another dense diffuse infiltrate here. Okay. Back to inflammatory. We see some pale stuff going on in here again. We start wondering if there are histiocytes in here. We start looking. And wow, look at all these cells in here. Small round cells with this abundant clear material, capsular material. Fairly large cells, larger than the tiny cells of histo, which have a tiny little capsule, not this gelatinous-like capsule. This is classic for crypto. The rhinosporidios in there, those are way larger, giant organisms here, not these tiny little cells with these capsules surrounding them. Nothing listed here looks like crypto in this list of choices. Lobo doesn't give you these large, clear staining gelatinous capsules like you see with crypto. Cryptococcosis. Sometimes the capsule is so prominent, you see mostly capsule and just really few number of organs. You've got a lot of organisms associated with it. So that's crypto. All right. It looks like kind of an incisional biopsy here. Neoplasm. Atypical keratinocytic proliferation. Some basaloid areas here, but we got all this squamous differentiation here. Lost our image for a second there. Something happened here. Well, let's go on it. Anyway, something happened with that image and I'm not able to pull it back up again for some reason. Here we go. So this is squamous cell carcinoma. Squamous cell carcinoma. Pretty aggressive. Got kind of a sclerotic pattern. Look for neurotropism. So they'll probably show you a classic example of squamous cell at some point on the exam. Okay, let's move on. 96. For some reason this keeps blacking out on me here. Okay. We've got an incisional biopsy or possibly an excision. Lesion is relatively well circumscribed, comprised of these aggregates of cells. Not sure why this keeps doing this, but keep going. This is a cellular blue nevus. Cellular blue nevus. These are blue nevus cells. You have a spindle cell blue nevus, cellular nevus, deep penetrating nevus, a lot of different subtypes of blue nevi. This is a cellular blue nevus in this case. Okay, 97. Another suppurative granulomatous dermatitis with pseudocarcinomatous hyperplasia. So you're going to be looking for bugs again in this case. Keep looking. Apologize for the technical difficulties here that we keep having for some reason. And we're going to look up in the abscessed areas. And this time, what you hopefully found were these spherules of coccidioidomycosis. Okay, so I can go back to this. I apologize, we keep having these. We're losing our computer image, I think, for some reason. Anyway, this was cocci. So go back and look at this one and find organisms of coccidioidomycosis in here. Okay, we're down to the last couple. This is a nevus, congenital nevus, nest of cells of the dermoepidermal junction, and also involving the dermis. I don't know what's going on with our computer. I really apologize for this. For some reason, I had to go ahead and then come back. But anyway, this is an example of a congenital nevus here. Cells around adnexal structures, small melanocytes, nests, no mitotic figures, totally benign. Didn't look like any of the other choices there. Okay. Now we're next to last case, nodular malignant melanoma, sheets of atypical melanocytes. So again, we have a few melanocytic lesions to close off with. This is a nodular malignant melanoma. A lot of atypical cells, a lot of mitotic figures. Pretty straightforward. Lots of mitoses. They have what are called dangerous dermatology questions on the exam, where they show something that's so obviously malignant that if anybody chooses benign, you automatically fail. Usually that's more of a clinical case. But just beware that they're going to show you something that's clearly malignant. Don't make the mistake and choose benign, and they may call you in and ask you a question about why you chose that. The last case, hopefully I'll be able to do it for you here. This case is also an infection, granulomatous. See all the histiocytes here, but look inside these histiocytes. This is histoplasmosis. So this is one of the intrahistiocytic disorders that gives you things like rhinoscleroma, histoplasmosis, leishmania. These all look a little bit different. And the organisms here, you can see are small, round organisms, little tiny capsules within the histiocyte, a different kind of capsular material than you see with crypto. I think maybe because we've loaded so many cases in here, it's overwhelming our system. But anyway, that's all the cases. This is recorded, so you can go back and look at these on your own. I think we may have a few questions in the chat room. So if we have any of those, we can answer them online. But anyway, hopefully this was helpful for you. I do pretty much guarantee that if you got 80 to 85% of these, you will pass the board. So for those of you third years, if you've missed some of these, go back and look at the ones you missed. But I think you're going to be very well pleased with yourself if you've got that percentage of the questions correct. So thank you all for attending today. I apologize for the computer glitches there at the last minute. Hope this was helpful, and good luck to you, those of you taking the exam, and those you're taking next year. You'll be well prepared if you know these cases now. Take care and good luck.